Department of Ophthalmology, Government Medical College, Chhatrapati Sambhajinagar, and coordinator for today's webinar. I welcome you all for this webinar. And it's an honor to introduce Dr. Piyush Bansal, who is the chairperson of the scientific committee of MOS. And I request Dr. Piyush Bansal to introduce our speakers, our faculties for today.
Thank you, madam. First of all, thank you again for this fantastic coordination and bringing forth our second series of glaucoma case presentations. So we have an excellent session lined up, and we're also very lucky to have Dr. Shirish Thorat from Akola, who's the president of the Maharashtra Ophthalmic Society, to also join us. Thank you very much, sir, for being here. We have two cases lined up for today by two residents, Dr. Apurva and Dr. Manisha, who've been excellently mentored. Dr. Apurva by our own Dr. Rekha Khandelwal, madam, who's a professor and head at NKP Salve, as we all know. And we've known to love her and admire her for all the work that she has been doing. And we also have Dr. Manisha, who's going to be taking up the first case, I presume now, who's been mentored by Dr. Swapnali Bandgar, who's assistant professor in the same institute at GMC Meerut, another historical institution of Maharashtra. So while you all both residents can decide who's going to go in first, I'll just introduce the expert panel that we have today. I'll begin with our state panel first. So essentially, both our expert panel are phenomenal, not just glaucoma surgeons, they're probably the king of statistics, as I would like to call them, as most nerve and pressure guys are, but these guys are exceptional. Both of them studied at CMC Vellore in Shela Institute, and under the guidance and the department which was known for Professor Ravi Thomas. And then both of them came and trained at LV Prasad Eye Institute. Dr. Rajul Parikh, who's our national faculty, was consultant at LV Prasad Eye Institute for many years, and then moved on to come to Mumbai and start his practice in Mumbai along with his better half, both of them being glaucoma surgeons, Dr. Shifali and Dr. Rajul Parikh, expert statisticians and surgeons. And the second one is Dr. Siddharth Dikshit, who's my friend since the last 2 decades almost, and a senior consultant at LV Prasad Eye Institute. Again, a fantastic surgeon, not just with conventional techniques of glaucoma surgery, but even the minimally invasive glaucoma surgeries. I'm very happy that both of them are over here, and our residents from our state can benefit from their immense teaching capacity as well as sharing ability. So with that, I would like to hand it over to Professor Archana Vare, and we can begin our cases.
Okay. So first case will be presented by Dr. Manisha Pawar, and she's a junior resident at Department of Ophthalmology, GMC Meerut. And her mentor is Dr. Swapnali Bandgar, assistant professor, Department of Ophthalmology, GMC Meerut. So I request Manisha to present her case.
Yes, ma'am. Good evening, everyone. I'm Dr. Manisha Pawar, third-year resident at GMC Meerut. Today, I will be presenting case report of primary open-angle glaucoma in young female under guidance of Dr. Swapnali Bandgar, who is assistant professor at our institute. Here is a case of 33 years old female who is resident of Ichalkaranji and who is handloom worker by occupation. She presented with a chief complaint of diminution of vision in both eyes since 8 months, which was more predominant in left eye as compared to right eye. History of presenting illness. She was already back, then she started noticing diminution of vision in both eyes, which was since 8 months, which was more predominant in left eye as compared to right eye. And it was insidious in onset, gradually progressive and painless. For this, she took consultation from general ophthalmologist from Ichalkaranji, who started her on anti-glaucoma medication, Dorzox T eye drop, twice a day, and advised her to get operated for the same. But the patient was non-compliant and discontinued anti-glaucoma medication after 1 month. And now she came to our OPD for increasing diminution of vision. Negative history. There is no history of ocular or head trauma. There is no history of ocular surgery, no history of colored halos, no history of redness, pain, photophobia. There was no history of headache, which was associated with vomiting. And there is no history of use of OC pills or use of steroid use in past. And there is no history of any over-the-counter medication use in past history. She is a known case of medicine since 4 to 5 years. She is on tablet thyroxine 50 mg once a day for the same. There is history of spectacle use from age of 12 years. She is using myopic glasses. There is no history of any other systemic comorbidities like diabetes mellitus, hypertension, asthma, and tuberculosis. A personal history is within normal limits, that is normal bowel and bladder movements with normal diet and sleeping pattern and appetite, and there is no history of any addiction. Her family history is not significant, that is no family history of glaucoma. General examination. Patient is conscious, cooperative, and well oriented to time, place, and person, and her general examination is within normal limit with no evidence of anemia, cyanosis, clubbing, icterus, or lymphadenopathy suggestive of any other systemic illness. Ocular examination. Her head posture is normal, facial symmetry is well maintained and normal. Her ocular movements are full, free, and painless in all directions, and her eyes are fixed at primary gaze, that is orthophoria. Her uncorrected visual acuity of right eye is 6 by 36 with pinhole. There is improvement of 6 by 6 checked with Snellen chart. And her left eye visual acuity, it has movement close to face, perception of light and projection of rays in all the quadrant is present. Our best corrected visual acuity is 6 by 6 with refractory correction of minus 1.5 sphere with minus 1 cylinder at 90 degrees. And near vision of right eye is N6 checked with logmark chart. Her eyelids are at normal position, that is upper eyelid covering 2 mm of cornea and lower eyelid just covering just touching the limbus. Her conjunctivas in both the eyes are normal with no congestion or circumciliary congestion. Her corneas are clear on both the sides with corneal diameter of 10 by 11 on both the sides. Her anterior chamber depth is normal with one hearing grade of grade 4 with optically clear media in both the eyes. Her iris shows normal color and pattern with no evidence of iris atrophy, posterior synechiae, or neovascularization of iris in both the eyes. Here is a picture of her right and left eye showing anterior segment of right and left eye, which is already described. Her pupil is single, central, and circular, 4 mm in diameter in right eye, whereas 5 mm in diameter in left eye. Her direct light reflex is reacting and well sustained in right eye, and left eye reacting and ill sustained. Indirect light reflex, consensual reaction is present in both the eye with relative afferent pupillary defect of grade 3 in left eye. Her lens is transparent on both the sides. Her IOP is checked with non-contact tonometer at 10:30 in the morning. She was not on any anti-glaucoma medication at that time. Her IOP was 35 millimeter of mercury in right eye and 60 millimeter of mercury in left eye. Gonioscopy was done with Goldman 4-mirror indirect gonio lens with non-indentation technology, which showed open angles in both the eyes, showing structures still ciliary body band in all the 4 quadrants. Her nasolacrimal passage was Ropla's negative in both the eyes. Her fundus examination was done by dilating pupils with topicamide and examined indirect ophthalmoscope with 20 diopter lens, and slit lamp biomicroscopy was done with 90 diopter lens. Medias were clear on both the sides. Her disc was average size with vertically oval shape and distinct disc margins with NRR thinning, which was more significant inferiorly than superior. Nasalization of vessels were present and bayoneting signs were present with vertically cupped to disc ratio of 0.6, which was deep cup. Her RNFL striations were seen in right eye. In left eye, disc was vertically oval with average shape and distinct disc margins with NRR lost in all the quadrants, and nasalization of vessels with mild disc pallor was present with vertical cup is to disc ratio of 0.9 is to 1 with deep cupping, and RNFL was lost in left eye. Her blood vessels show 1:3 arteriolar attenuation in both the eyes, with normally emerging blood vessels from optical nerve head with dichomatous branching in both the eyes. Her mid-periphery was tessellated in both the eyes, and macula showed normal foveal reflex in both the eyes. Here I have attached fundus photographs of her right eye. Here we can see her disc size is her disc shape is vertically oval with no average shape and distinct margins, with vertical cupped disc of 0.6:1, with the NRR thinning, which is more significant inferiorly as compared to superiorly, and RNFL striations are seen. And nasalization of vessels along with bayoneting sign can be seen. Here is the picture of her left fundus showing optic disc, which is vertically oval with the average size and distinct margins, with vertical cuppage to disc ratio of 0.9:1 with deep cupping. Nasalization of vessels along with bayoneting sign is seen, and NRR is lost. With the RNFL is also RNFL is lost. Here is the disc diagram. My probable diagnosis is both eyes juvenile open angle glaucoma, with left eye advanced glaucomatous optic neuropathy and right eye mild glaucomatous optic neuropathy, with both eye compound myopic astigmatism. We advised her some investigations like blood investigations, which showed here uh, hemoglobin of 12, which was normal, and normal lymphocyte and neutrophil count. Other tests were normal, and her thyroid function test was done as she was known case of hypothyroidism. Her T3 level was 115 nanogram per DL, and T4 level was 11.30 microgram per DL, and TSH level was 4.3 micro international unit per ml, which means her T3 and T4 levels are within normal limit, but TSH is slightly raised. Her B scan showed right eye axial length of 24 and left eye axial length of 26 millimeter. Ocular investigations were done like pachymetry. Her right eye pachymetry showed 555 microns of central corneal thickness, and left eye pachymetry showed 540 microns of central corneal thickness. Her perimetry was done with Humphrey's visual field analyzer 24-2 fields. Here I have attached photograph of perimetry. Here is the photograph of perimetry of 33-year-old female with a visual acuity of 6/6 with correction. It was done with white stimulus with the size of 3, and done with the theta faster strategy. Her visual field, her reliability indices are within normal limit, that is fixation loss is 0, and false positive rate errors are 1%, and false negative errors are 2%. Her visual field index was 98%, and total deviation and pattern deviations are within normal limits. OCT was not done as patient was not affording, but it is important investigation to see the progress of disease in young adults. Management, we started her on 2-tablet acetazolamide 250 mg along with syrup potassium chloride 5 ml diluted in half glass of water. After checking her blood pressure, we started her on injection mannitol 20%, which was 300 ml IV over 20 minutes stat. Topically, we started her on in right eye, we started her on travoprost eye drop HS, and in left eye, travoprost eye drop HS along with dorzoxy eye drop BD. IOP was recorded 30 minutes after giving injection mannitol and starting topical anti-glaucoma drugs with non-contact tonometry at 12:30 p.m. Her right eye IOP was 23 millimeter of mercury and left eye IOP was 35 millimeter of mercury. We discharged her with discharge medications of tablet acetazolamide 250 mg BD for 3 days along with syrup potassium chloride 5 ml diluted in half glass of water. And topically, we started her on right eye travoprost eye drop HS, and in left eye travoprost eye drop HS along with dorzoxy eye drop BD. Follow-up was advised after 1 week as patient was young and non-compliant to treatment. IOP on first follow-up after 7 days after stopping tablet acetazolamide and continuing topical anti-glaucoma drugs which was checked with non-contact tonometer at 10:30 a.m. in the morning. Her right eye 20 millimeter of mercury and left eye was 26 millimeter of mercury. Her target IOP, according to calculation, is right eye 18 and left eye 12. As target IOP was not achieved in right eye, we added Dorzox T eye drop topically in right eye and advised a follow-up after 7 days. IOP on follow-up was checked with non-contact tonometer at 11 a.m. in the morning. Right eye was IOP was 15 millimeter of mercury and left eye IOP was 24 millimeter of mercury. And follow-up was advised after 7 days. We'll plan her next follow-up after 4 to 8 weeks and later on after 3 to 6 months. On follow-up, her IOP will be checked and fundoscopy will be done. Every 3 monthly, we will get her perimetry done to check for visual fields. If she responds well and is compliant to medication, it will be continued. Otherwise, we will advise her surgical management. Thank you.
Nice presentation, Dr. Manisha, and I congratulate you and your mentor, Dr. Swapnali. And
Thank you, ma'am.
now I would request Dr. Siddharth to ask questions to Dr. Manisha.
Right. And even before that, I will have to say that you have proved, Piyush, that Ghar Ki Murgi Dal Barabar. Dr. Rajul is so much senior to me and of so much more experience that
Go ahead. Ask questions. Go ahead.
No, please, you
Go
can
ahead.
start,
Discuss.
Dr. Rajul.
Yeah, I request Dr.
Please
Rajul
go ahead.
Parikh
No issue.
to ask questions.
Siddharth, go ahead. Ask questions. No issue.
Dr. Rajul, if you know me, if I start, I won't stop. That's the
No
problem.
problem. No problem. Go ahead. Go ahead.
Right. Very well presented, Manisha, and
Thank you, sir.
congratulations to that. It is not easy to present in a fora where hundreds or maybe even thousands are watching you, and you did quite well. And with my experience of conducting exams and looking at examiners and managing glaucoma over the last few years, much less compared to Dr. Rajul, I would add a few things. The first slide, the title slide that you shared, was said that a case of POAG in a young patient, right?
Yes, sir.
So there, the terminology you used was different from what you used in the diagnosis. Yeah.
Yes, sir.
It is very important to differentiate between primary open-angle glaucoma, which is typically defined as open-angle glaucoma of not a secondary origin in people above 40 years of age, and GOAG for three reasons. One thing is the natural course of the disease. You will never see pressures of 45 and 40 in a patient with POAG. It's a very gradually progressive disease compared to JOAG, which suddenly kind of decompensates and you get very high intraocular pressures. And given the fact that patients with GOAG have a very long life to live, so your treatment will be much more aggressive in these patients, because if you don't really meet the target intraocular pressure, you will have to be very aggressive, like you and your professor was in this case. So you have to be a little more aggressive in patients with GOAG. And the overall prognosis that you would have for these patients is also different. A few small pointers which may prove to be very important in exams. So when you say that this patient had movements, vision of counting fingers close to face, I didn't really understand the hand movement CF thing. What you're supposed to do is to get the patient closer to the Snellen's chart and measure the distance at which they can read the largest letter on the Snellen's chart. And that is how you can represent the vision, measuring the distance and converting the 6 by 60 to whatever the distance the patient read from. And when you mentioned Von Erich's grade 4, right?
Yes, sir.
So that was a interpretation. The finding has to be the peripheral anterior chamber depth was equal to 1 corneal thickness or half corneal thickness or between half and 1 corneal thickness, right?
Yes, sir.
And you also mentioned in your slide, though you spoke correctly that the size of the optic disc was normal, right? So all sizes of the optic disc are normal. If I am bald, it doesn't mean that I'm abnormal, right? So a small optic disc is as normal as a large optic disc.
Large.
It is our interpretation which depends on that. So they have to be normal. All of them have to be normal. You just have to mention average size, large or small.
Medium.
Yeah. And when you showed the fundus photographs, I believe, Manisha, you kind of tried to fit them into one slide, and the proportion of the fundus photos got changed.
Okay.
So whenever you drag any corner, please press the control button on the Windows PCs and laptops. That will allow you to retain the original size or proportions of the thing.
Yes.
And I would really like you to go to the visual field printout of the right eye that you showed. Of course, the left eye, the visual field was not possible. It is of critical importance to hide the personal names and data of the patient, which you missed to do. And you said that this was normal, right? I would beg to differ. And are you able to share your slides now?
Yes, sir. Yes, sir.
Right. Please go to the 24-2 visual field of this patient.
Yes, sir.
And if you pay close attention to the paracentral and central points in the superior hemifield, they are not normal, right? They may be suppressed to levels of P less than 5% and P less than 1%.
1%.
But this warrants examination on 10-2.
Okay.
Can you tell me why?
As in case of 10-2, the points are closely aligned and more points can be seen. As in
Right.
case
So,
of 24-2, only centrally 12 points can be seen. In case of 10-2, 16 points can be checked within central 5 degrees.
right. So both these points fall in the purview of the 10-2 visual field. And it feels like I would expect a visual field defect to show up on 10-2 in this patient. So probably on follow-up, you can do it. You did not mention the vision on follow-up, especially in the left eye after intraocular pressure got controlled. Did it
So there
improve?
was no improvement in vision in left eye.
Okay. So that's unfortunate for the patient. But many a times in glaucoma, especially when you see these lens-induced glaucomas, you think that it is PL negative or PR inaccurate, and you get the intraocular pressure controlled with a surgery, and they come back to you with 6/6 vision. So that's not uncommon. Never assess the optic nerve function in terms of either vision, relative afferent pupillary defect, or pupillary reactions. Basically those two things. When the pressure is uncontrolled and very high as 60 millimeters of mercury.
Yes.
So reassess when you see them on follow-up. And I think if this patient, my basic question is, I don't know how this works. Look, I've been out of the government setup for more than 20 years now. But all the investigations that we did in our hospital were free of charge. Is OCT not free of charge in your hospital?
Sir, actually, it is not available at our institute.
Okay.
Yes, sir.
Right. Just wanted to correct one small thing is that OCT is not only important for progression. Of course, it is more important for monitoring progression, which is very important in a patient who has lost the left eye and has only the right eye to see and survive for the rest of what I believe, if everything else is fine, 50 or 60 years, given the modern day life expectancy, to monitor progression. So I think it's a challenge to treat patients in the government hospitals And many of our patients are like that. So I really hope that you can manage some samples for the patient and call this patient once every month and give them the medications that is required. And if the left eye you have really given up, we can probably help them by stopping the medications in the left eye. If
Okay,
we are
sir.
thinking
Okay,
of
sir.
just counting fingers 1 meters and CF close to face, that's not really a useful vision. If I'm not saying this is correct in the ideal world, you should never give up on that vision. You don't know if tomorrow in a Diwali, if the sun's firecracker damages the right eye, the left eye vision will become very important.
Yes, sir.
But if we have to choose between continuing medications for 15 days for both eyes versus 30 days for the right eye only, I would choose the second option if it comes to that. So let's see how the patient is following up. And I'm quite sure Dr. Rajul will have a lot to add here.
Yeah.
Dr. Rajul?
Rajul
So,
sir, could you please ask your
yeah,
questions?
sure. So the lots of points Siddharth has already covered. So first thing, when you look the perimetry, the
Yes,
first
sir.
field has to be discarded most of the time,
Yes, sir.
unless it's absolutely reliable, which is
Yes,
very
sir.
rare. Even in this, I am not talking about reliability parameter only. So the first point you get that if you look the total deviation and pattern deviation, the pattern deviation, the central is showing more points, which is usually unusual. Because what happens at the, we take seventh highest point when we adjust the halo vision. So
Region.
most of the time, total deviation would have more points compared to the pattern deviation plot.
Pattern
In your
deviation.
patient, if you see pattern deviation plot has more point in the center. So Siddharth was talking about 10 raised to, which is absolutely right. But it's also possible that this is most probably a learning error, which is
Sir,
most of the
actually,
time.
this is the second perimetry.
So sometimes patient do not learn. You have to repeat third time also.
Okay.
So
Okay,
you have to
sir.
see that what is the first field, what is the second field. Sometimes you require third field
Yes.
also. And sometimes
Okay.
patient may not learn at all. That also happens, and that's why OCT is helpful sometimes because some patients just don't learn how to do field. So the way back in late 90s when the full threshold program was there, the paper I read remember that 15% of the people could not learn perimetry even despite doing three times. Now Sita is better, but still the learning area is always an issue. The
Yes.
second point was that if you are doing 24 days to C, which is a central point, the faster
Oh,
strategy I don't mind because it gives extra point. But otherwise, Sita standard is little better compared to Sita faster,
yes.
more robust. So I would rely more on if you are doing 24 days two only, then Sita standard is better than Sita faster.
Okay, sir.
Unless the patient cannot. This patient is only 33-year-old, right?
Yes, sir.
So you can easily do the 6-7 minutes of the test. It's not a big deal. The the one other point you mentioned vision of only finger counting close to face, but your disc finding was zero
On
point
left
0.9
eye.
bipolar notch, so it doesn't correlate.
Yes, sir.
If you have zero point 0.9 bipolar,
Okay.
that means some amount of the rim is still left, and patient would have some vision, maybe 3 by 60, maybe 2 by 60. Was Siddharth was telling you to take the patient close to the field,
Final chart.
the Snellen chart and take the vision. So you can convert into 1 by 60, 2 by 60, 3 by 60 like that. But otherwise, and the disc photograph was not, you have taken the fundus photograph, not the disc photograph. So that's why it is more showing the whole posterior pole, where you should have taken only the disc photograph and it would have been shown more the disc more clearly. So otherwise, if it's zero point 0.9, then vision is not matching up. Most probably the disc is more damaged. In that case, you can write on 0.95, 0.99, which it most probably it would be like that because you have written no rim. Zero point 0.9 and
Yes.
no rim is not matching. Zero point 0.9, that means some amount of rim is left. So that finding is very important. And other, I mean, from management point of view, it doesn't make much difference. But if you're doing exam, if the patient has vision of PLPR and orthophoria, um, it can happen, but it usually is issue because patient is not able to fix it with one eye. Then why orthopedia? So that can be an issue. Otherwise, any other diagnosis, Siddharth already mentioned, 33 years is not POIG. It would fit into juvenile open angle glaucoma, and it fits your clinical picture because the patient has such an advanced damage in younger age. The juvenile open angle glaucoma is more resistant. They have more higher pressure compared to POIG. So your pressure of high 50 is matching with GOIG rather than POIG.
Yes, sir.
So that diagnosis, because in exam is very important. When you manage the patient, it may not matter much, but in exam they will ask a diagnosis. And if you write, say GOAG in 33-year-old, so the problem will start from there only. Okay. So it has to be GOAG diagnosis and not POAG. Okay.
POH.
Otherwise, the management, of course, aggressive. It has to be very aggressive. So GOAG, they are resistant to medical management. So you have to be very aggressive, lower the pressure because not only is only 33. So even if you look average life, he has at least 40 years to go with one eye. So you have to be more aggressive. You cannot be relaxed. You have to make sure that he achieves the target pressure, maintain, and if necessary, add medicine. Think of surgery if the IOP is not well controlled. That is the later on follow up, but you have to be aggressive in GOAG because they are usually resistant.
Yes, sir.
Okay.
Yes. Thank you, sir.
Thank you, Dr. Rajul, for that expertise, and I'm sure everybody would benefit from the pearls that both of you have shared. And now we'll go to the next speaker, that is Dr. Apurva, and she'll present her case now. Dr. Apurva, will you please share your screen?
Yes, ma'am. Ma'am, should I start?
Yes, Apurva, you can begin. We can see your presentation and your slides.
Please start.
Yes, ma'am. Good evening, all. Today I'll be presenting a case. My name is Dr. Apurva Khadakbhavi. I'm a resident of NKP SIMS Nagpur. My mentor is Dr. Rekha Khandelwal, ma'am. She is our professor and head. 20 years old male patient came with complaints of redness in the right eye since birth. Reddish discoloration of his face on the same side was present since birth. Gradual diminution of vision in right eye was noticed since early childhood. Patient gave history of redness in the right eye and reddish discoloration on the right side of the face since birth. He gave complaints of diminution of vision in right eye, which is gradual, painless, and progressive in nature since childhood. Unilateral headache was present since 4 years. He visited dermatology clinic for reddish discoloration on the face, for which he was prescribed some lotion, and then he was referred to ophthalmology OPD. Past history includes no history of convulsions, no history of developmental delay and mental similar complaints in his siblings, parents, and other family members. No history of hypertension, diabetes, bronchial asthma, TB, and thyroid disorder. Patient is conscious oriented and his vitals were normal. Facial cutaneous capillary malformation was noted, known as portwine nevus or facial nevus flammeus on the right side. Portwine stain with hemifacial hypertrophy was noted on one side of the on right side of the face, including the forehead, nose, cheeks, and the eyelids and upper lip. Lower lip, chin, and ears were not included. On systemic examination, CVS, RS, and abdomen examination was within normal limits. On CNS, a normal higher function was noted, no neurological deficit. Psychiatric mental status evaluation, patient had average intelligence and no evidence of learning disability. Other investigation we did were dental examination showed a bright red gingival overgrowth on the right side. Left side appeared normal, which was associated with blanching on applying pressure, suggesting angiomatous enlargement. Right side, right eye ocular examination. Visual acuity was 6/60. Conjunctiva showed dense dilated episcleral venous plexus. Corneal epithelium, stroma, and endothelium were intact. No edema was present. AC anterior chamber depth 1 Herrick's grade 4. Iris showed color on iris color pattern was normal. Pupil central circular 4 mm. RAPD of grade 2 was present. Lens is clear. Intraocular pressure with Goldman applanation tonometry was done, which was noted to be 26 millimeters of mercury. Fundus examination. Slit lamp biomicroscopy with 10D lens. Disc showed well-defined margins. CDR was 0.8. Vertically elongated cup with superior and inferior neuroretinal rim thinning. Nasalization of blood vessels is present. Blood vessels appear normal. MFR was dull. Increased reddish hue is present, obscuring the choroidal details, suggestive of diffuse choroidal hemangioma. Gonioscopy of right eye with 2-mirror gonioprism. Angles are open up to pigmented trabecular meshwork. Blood in Schlem's canal was noted. CCT showed 515 micrometers. Axial length was 22.98 millimeters. Left eye ocular examination. Visual acuity 6/6. Conjunctiva showed ampuliform dilatation of conjunctival vessels. Corneal epithelium, stroma, and endothelium are intact. No edema was present. Anterior chamber depth of VH grade 4 was noted. Iris showed a normal color pattern. Pupil pupil is circular, central 3 mm, reacting well. Lens is clear. Intraocular pressure with Goldman applanation tonometry was 12 millimeters of mercury. Slit lamp biomicroscopy with 90D lens of left eye. Disc was round with defined margins. CDR 0.4:1. Healthy neuroretinal rim is present. Blood vessels appear normal. MFR is seen. Gonioscopy of left eye with 2-mirror gonioprism showed angles open up to pigmented trabecular meshwork. CCT central corneal thickness of 515 micrometers is noted. Axial length of 22.98 millimeters. This is the image of right eye RNFL OCT. RNFL thinning is present in the superior and inferior quadrants, correlating with superior and inferior notching. Then perimetry of right eye was done, 24-2 perimetry of right eye, which showed advanced glaucomatous field loss on grayscale with mean deviation of minus 29.92 decibels. And so 10-2 perimetry was done to rule out macular threatening. On left eye, then left eye RNFL OCT shows superior and inferior thinning with early glaucomatous damage, and left eye perimetry of 24-2 showed early superior and inferior field defects with mean deviation of minus 2.54 decibels. OCT angiography was advised, which showed right eye increased thickness in right eye. On B scan, choroidal thickening was noted, which was more in right eye than left eye. CT brain plus orbit and MRI was done. No intracranial or intraorbital calcification was noted on CT scan. Leptomeninges appeared normal. Intense post-contrast enhancement of right ocular coat suggestive of diffuse choroidal hemangioma. Medical management, patient was started with topical anti-glaucoma medication, and we are waiting for IOP to lower so that we can do surgery, which is planned in the coming week. Initially, to reduce IOP, fixed drug combination of timolol and brimonidine started twice a day. Systemic propranolol 50 mg twice a day is started for 1 week. Then trabeculectomy with anti-fibrinolytic agent is planned after 1 week. For left eye, we will do close follow-up and repeat visual field testing. My differentials are secondary glaucoma associated with Sturge-Weber syndrome and Klippel-Trenoré-Weber syndrome. Provisional diagnosis for my case is Sturge-Weber syndrome with right-sided portwine stain and facial hypertrophy with late onset secondary glaucoma and choroidal hemangioma. Thank you.
Uh, Very nice presentation, Dr. Apurva. And now I request Dr. Siddharth, or I'll start with Dr. Rajul Parik to ask questions to Dr. Apurva.
So, Apurva, the
Yes, sir.
first question, have you taken consent for patient's photograph to be shown?
Yes, sir. We had taken his
Written
consent.
consent we have taken because you have revealed the patient's identity, which is medico-legally issue if you have not taken consent.
Yes, sir. The consent was
Okay.
taken. So
So
I
then let's
would.
go. Hmm?
Yes,
You have taken.
sir. Yes, sir.
Right. So let's go to the disc and field. The left eye disc you mentioned 0.4 cup disc ratio, right?
Yes, sir.
And then in field you showed superior and inferior depressed points and OCT also superior NFL thinning. So do you think it correlates with your
Sir, it
clinical
is
findings?
not correlating. So we are planning for repeat perimetry and
So,
RNF.
because
Yes,
you
sir.
have to, the first field is, as I mentioned in the previous case also, there's a learning error.
Yes,
So
sir.
I'm not talking about the disc. There, the learning error happens to most of the patients, so you have to repeat. But I will now talk about, ask you about OCT. So
Yes, sir.
you think that OCT having RNFL, showing RNFL thinning the red means the patient has glaucomatous changes?
Uh, yeah, yes, sir. When there is a
No, it is not like that.
yes,
It is that's why we called it red disease and green disease. The red disease means that patient may have a red color. That means it is abnormal, but doesn't mean that disc is abnormal. Okay, and on other extreme, you may have a
Green,
normal
green disc.
OCT, but definite disc changes. So
yes,
that's why you have to be very careful when you say OCD finding suggesting glaucoma. You have to correlate clinically.
yes,
The the next thing, uh, when you talk about medical management, what precaution we should take if we are doing trabeculectomy in patient who has definite choroidal hemangioma?
sir. To prevent choroidal abnormalities, sir, we will start the patient on systemic propranolol.
That I read, and propranolol is not foolproof plan.
Yes, sir.
Propranolol, the whatever literature you have read, it is not working in every patient. So
Yes,
propranolol alone is not going to help you. So what else you will require to do when you are doing trabeculectomy? So in usually in my practice, if patient has choroidal hemangioma, I would think of doing tube first, but I'm not saying trap cannot be done. So if you are doing trap, then what definite surgical modifications you have thought about?
sir. To
So what
reduce
are the risks? So what are the surgical complications which is more common in patient with stress Weber, especially in presence of hemangioma?
yes, sir.
What are the complications?
Sir,
Firstly,
there may be expulsive choroidal hemorrhage.
the suprachoroidal hemorrhage is a better terminology rather than
Yes, sir.
expulsive hemorrhage. And the second is effusion,
Effusion,
the
sir.
choroidal effusion. Both are very common. So when you're doing trabeculectomy,
Yes, sir.
usually you should make sure that there is no hypertony at any point in time.
Yes, sir.
So you and the risk of effusion and hemorrhage. So what we do usually
Sir,
do a
we have to. Yes,
sclerectomy and do the sclerotomy before you do the trap.
yes, sir.
Second, make an antechamber maintainer or put a high molecular viscoelastic. So there is no sudden hypotony because that is a risk factor for developing hemorrhage or effusion. So you have to be very careful doing the surgery. And as I mentioned, left eye, the disc look healthy to me. So repeat the field before you think about glaucoma, because the Sturge Weber usually is unilateral, because
Yes.
they have unilateral pathology. Okay.
Yes, sir.
I would like to ask, I would like to request Dr. Siddharth to ask questions to Dr. Apurva.
Yeah, no, I think this was a wonderful presentation. And
Wait, one
give,
second, Siddharth. One
yeah,
second before. You presented optic disc finding before gonioscopy, which is
Yes.
not correct. When you present in exam, you have to have gonioscopy before your optic disc finding. Huh?
Yes, sir.
yeah,
You cannot have optic disc examination before gonioscopy.
Yes.
Otherwise, you'll be in trouble in exam. So I
Yes.
didn't mind clinically. I don't mind, because everything is important. But when you present in exam, you have to be thorough, systematic. So first thing comes first. So your
Yes.
IOP comes before gonioscopy, and optic disc comes only after gonioscopy. Don't forget that.
Yes, sir.
Ah.
right. And was it a slip of tongue when you said 10 diopter examination of indirect ophthalmoscopy, or is it a lens that I'm not aware of? I'm sure it was a slip of tongue, so no matter, no, don't bother about that. I think it was a wonderful presentation, and I was really very impressed. Look, I don't deal with pediatrics, so I don't deal with these cases that much. So pardon my ignorance, Apurva and Rekha madam, if this is just my ignorance, but the dental examination and the findings there was really amazing. I was very impressed with that. And Apurva, do you know what kind of protocols did initially emerge about the treatment with propranolol, and what kind of reservations that people had when this treatment started? Because this happened around the time of my residency, so I'm pretty aware of it. And the last journal club that I did in my residency was related to a case similar to what you presented. So are you aware of that?
Mm. Mm. Mm.
So I would still congratulate you, because you have missed the question, which was the difference between just passing and getting an honors or distinction, whatever you call it in your state. Okay, so uh, going through the history of literature in terms of what has happened over time, because in when I was a resident, we were only talking about hemangiomas and intravenous versus oral propranolol, and what role did they play in reducing the complications of surgery. And over time, it has been proven that oral propranolol might be as effective as intravenous propranolol. Otherwise, there were protocols where patients were administered propranolol under GA and observed for some time, and then they were discharged. So if you actually take the pain to go through the literature, and this is something that Kansky will not tell you. Dr. Rajul will understand when I say that probably both of us have never read Kansky. We were not allowed to read Kansky. Kansky for us was an atlas. Parsons was the basic book, and then it was everything else. So if you go through the classical textbooks, you will be able to explore a lot beyond just the current status of knowledge and the evolution of knowledge. And I'm telling you that you are on the border of distinction. I'm quite sure that madam has a lot to do with it, but you have lived up to the expectation, and it is just on the verge of just crossing the threshold and launching into space. Congratulations.
Thank you, sir.
Okay. Rajul sir, would you like to ask questions from the exam point of view?
No, no, only thing that if you have a Sturge-Weber syndrome or something, then you should know the classification of the pediatric glaucoma. So that the resident, that the
Apurva, can you
systemic
answer that?
atrophy is associated.
Apurva, can you answer that, Apurva? Sir has asked you something. Classification of pediatric glaucoma.
If you don't, that would not be in textbook. So that if you Google it, you will find it out.
Manisha, would you like to attempt?
They don't Google it, Dr. Rajul, anymore. They what Meta AI or what Perplexity AI the thing and
Well,
gives the summary of everything.
Okay.
so that if the examiner has glaucoma interest, and that is a question they can ask. Otherwise, she covered everything quite nicely.
Okay. Manisha, for your case, there was PPCA. Can you tell us what is PPCA?
Dr. Manisha, you are muted. Can you unmute yourself and then speak? Yeah.
What is alpha zone? What is beta zone? Do you have any idea regarding that?
Yes, ma'am. Alpha zone is a peripapillary atrophy, which is present just near the near the margins of optic disc, which is due to mottling of pigmentation due to due to loss of retinal pigment epithelium. And there is beta zone, which is outside the alpha zone, which is due to loss of retinal pigment epithelium, and choroidal vessels will be heavily visible with there. It is
And
beta atrophy.
which is more significant, alpha or beta?
Beta atrophy is more significant as compared to alpha, and it is one of the corroborative sign of suspecting glaucomatous disc.
And what is haloglaumatosis?
Sorry, ma'am.
Okay, when it is present 360-degree around the optic disc, it is called as haloglaumatosis. Dr. Siddharth, would you like to ask questions to both of them?
Yeah, one question to Apurva. Apurva, I'm a mixed person. I do GAT, I do iStents, KDB, and bank. Would you consider any of these in any of your patients believing the fact that it will spare the conjunctiva for the rest of the procedures?
Sir, they are doing MS, right?
It would be more pertinent if
No,
you
let because it is
the full forms of what you were asking them.
yeah. So the thing is, I learned my post graduation from a professor who would ask the question a step beyond what we have learned.
Sure.
Right. So let me explain to you. Like there are procedures where is the greatest barrier that lies in open angle glaucoma? It lies at the juxtacanalicular meshwork, right? Okay. And with the minimally invasive or more in fashion now, the micro-invasive glaucoma surgeries, you can overcome this barrier by either inserting a stent in the trabecular meshwork or actually incising it or excising it. Would you, in your conceptual mind, would you think that one of these procedures is a good procedure for your patient? This is extrapolation, right? So you're getting another question for your distinction in your MS exam.
Sir, first we will plan trabeculectomy with antimetabolite, preferably mitomycin C. If
You are hurting a
that
mixed surgeon. You're
uh,
hurting a mixed surgeon.
yes.
Are you going to rule out mixed surgery? Minimally invasive, micro-invasive, conjunctiva
Don't
spared.
get confused in exam. Siddharth, don't confuse her. In exam, later speak trabeculectomy. The general examiner will get angry
No,
if
no,
she talks about mix.
Yeah.
So later talk
And
about
and
is the
if
first
this
choice.
patient
Don't get confused.
mixes the most unsuitable surgery, right? Right,
So
because you
otherwise
have
also,
raised episcleral venous pressure. If you do
so
a
otherwise
mix
also
in
both.
this patient, it is going to be a disaster. You are going to get a full chamber hyphema on day one, and you don't know even what else will you get. So I was laying you into a trap,
Any patient
and
is.
These are very good questions. These are very good questions and answers by Dr. Dikshit. He's trying to lure you into a trap and trying to find out how your understanding of the basics is over here. So please try to understand that. And I think we are very close to the end of the session with this excellent. I thoroughly enjoyed it. Yeah, but I'll leave it to Dr. Archana Vare and Shirish Thorat sir if he's there. But I would also want some general comments from both of our experts after these fantastic presentations by both Manisha and Apurva.
Okay, so as a postgraduate examiner, the most common questions that are asked in the exams for MS are like, what are the optic disc changes in glaucoma? Then, what are splinter hemorrhages? What is the significance of them? Then, how will you classify the glaucomatous damage? These are like more asked for MS students. The glaucoma is a very important case, and it is very, very frequently they have the glaucoma case, and they have congenital glaucoma case also, and they have the adult glaucoma cases also. So primary open angle glaucoma, angle closure glaucomas, all the cases are there for MS students. So with that, I think we are towards the end of the session. I would request Dr. Shirish Thorat sir if he's available to give his
Yes, yes,
comment.
ma'am. Yes, yes, yes. And it's really wonderful PG session, and I really, proud of these brilliant students who have presented the cases, and I feel they're lucky to get mentored by some of the finest teacher of the institutes, and they're getting, experience as a big platform because of MOS PG series. I really thank Dr. Khandelwal Madam, who is known for her academic excellence in our area, and also Swapnali Madam. And Rajul Parekh is a known figure from Bombay. Many of us are his students. And let me tell about Dr. Siddhar. My place is around 600 kilometers from Hyderabad, and he is a great clinician, academician, and he is most popular figure not amongst the ophthalmologists, but also from in the patients from this area also. Really, thank you, sir, for your wonderful comments and guidance. And lastly, our scientific committee is doing a great job under Dr. Piyush. And hats off to you, Archana Madam, for carrying this program so nicely. Yes, it's like a feast to watch. Yes, thank
sir.
you. Yes.
Dr.
Thank
Raju
you.
and
Thank
Dr.
you,
Siddharth,
everybody.
would like to give some concluding remarks.
No, I think we both presented very nice. So good job.
Okay.
That's some general comments.
yeah, just a few things. Uh, Look, we are from a generation where the parents or grandparents of our patients would have only known one thing. Are they seeing or are they not seeing? So when you say family history of, if their parents were not seeing, they would have never known why they were not seeing. So you have to mention it as family history of any major ophthalmic problem. And just one more thing is that when you move from one section to another, right? Like you move from chief complaints to uh, the present history of the history of present illness. So how do you move? Do you say history of present illness and then you start your comment? Or do you say the patient complained of acute painful reduction in vision? However, when the last time the patient had any ophthalmic consultation, the patient was absolutely fine and developed these symptoms only 8 months back. So, what is the difference? The difference is that you're following a script that has been ingrained into your mind versus telling a story. Who is the person that you want to watch a documentary or Rajkumar Hirani, where he would leave a link to the next slide in the previous slide, and seamlessly would you move to that? If you can mesmerize your examiners with your presentation, they will forget half your question. They will forget everything. I am really telling you, if you can mesmerize them with your presentation of the case, they will forget half their questions and you have already passed. If they didn't have to stop you in between your presentation of the case because they were so mesmerized about the presentation. So presentation of a case should be like a poetry that you are able to understand everything. Why do you have to say, coming on to general examination? You say, after completion of the ophthalmic examination, I proceeded to examine his heart, the lungs, the GI, and everything turned out to be normal. That is sufficient. You don't have to pretend. When the examiners ask, you can say S1, S2 was normal. And as in Apurva's case, they were actually important. And you actually pointed out those things. So present it as poetry. Because I saw the pigmentation on one of the hemifaces, I decided to examine the denture. Who in this general world is going to believe that you are going to examine the denture of every patient? Right? Nobody is going to believe that. So present that dramatically. Because I saw the pigmentation on one of the hemifaces, I lifted the lips and I discovered, yeah. So present it like drama. Because examination is drama, right? You either pretend to not knowing anything at all just in order to pass, or you pretend to be under the level of where you are in order to pass. But you have to understand there are levels of drama. There is a subtle drama of Satyajit Ray, there is a Karan Johar movie, and there is a David Dhawan movie. Where you want to land at, but you have to generate drama. It should sound like a story. It should not look like there is a heading, I read out the heading, and then I read out the subpoints. In general presentations, every time when you present, what you speak has to be absolutely different from what is written there. That is when people will listen to you. Otherwise, they will close their ears. People mentally can, even if you don't believe, and start looking at the slides. So if you can draw them away from the slides, and if you can present images which is helping them do that, draw them away from the slides to your words. That is a winning presentation.
Marvelous. Marvelous.
Yeah.
So, these are master words for you, Manisha and Apurva, and anybody who's watching, because I mean, nobody else could have presented it the way that Dr. Siddharth just did. I mean, you have to build a story and you have to captivate the audience as well as the patient. These are soft skills that you will learn later. But as of now, we focus on science, on facts. And thank you so much, everybody. Archana, madam, could you just close the meeting now. It's been very late, and
Yeah.
thank you so
Thank
much.
you.
Thank
Thank
you
you,
so much.
Dr. Swapnali and Rekha ma'am. Thank you so much. And congratulations to both the presenters. Thank you, Thorat sir. Thank you, Siddharth, Dr. Siddharth sir and Dr. Rajul sir. And हमारे पीयूष सर तो घर के ही हैं. Thank you, Dr. Piyush.
थैंक यू अर्चना मैडम, महाराष्ट्र मेरा दूसरा घर है.
Oh, yeah. The next time I'll invite you to Chhatrapati Sambhajinagar then.
क्या बात.
I didn't know. Anyway, it's a
Aurangabad is
discussion for another
frequently
time.
named as
Okay,
Chhatrapati.
Sunil ji, can we close the meeting? And because it's a very
Yeah.
nice meeting, so we can perhaps maybe have a minute
Yeah.
after this. But Sunil ji, can you close the live meeting?
Thank you.
But before everything ends, thank you, Sunil ji, for everything, and Todd,
Thank you.
but especially Sunil ji for these fantastic, uninterrupted, fantastic meetings.
Right. So the live meeting is